I'd like to open it up to our participants to talk about not only the topics that we've talked about, but where are some of the solutions that some of our participants see, and you can test them against some of our panelists. You can share them with us. So we're going to open this up through the chat, as well as Katie, if you could help us kind of run traffic cop on that and help us get feedback from our participants and other panelists.
And Mike, can I close with one thing? I just want to give, I see Kelly Maynard is on the line, and I just want to give her a particular shout out because Kelly and her team have helped lead our Access Working Group for the last 2 years, and really have contributed so much to understanding, what are the access issues and that the community is facing, and really helping work side by side to find some solutions. And so Crystal Davis is on the phone and will be taking over for Kelly next year as Kelly's term is over. And so you've got a rock star crew on the line, and I just really wanted to say thank you to Kelly and her team.
Oh, Jamie, thank you. Right back at you, my friend. It's been a pleasure working with you all.
I think all of us can't say thank you enough to Kelly. So
you guys are too sweet.
Kelly was one of the first instigators as we were forming RAAP. And so she's been a particularly a good friend and someone that I bounce things off of when I need guidance or advice. And so I would concur with that, Jamie. So we do have a slide up here to help us spur forward some of the discussion. Katie?
Mike, that was for a different panel.
Oh, was it for a different panel? Okay.
Sorry about that, yeah.
So I would ask Angie to jump in here with me really try to facilitate dialogue with all of you on what you think about some of these current efforts. Where are some areas that we should focus on moving forward? RAAP is continued to, and I appreciated Congressman Peters' comments. RAAP has been involved not only with Congressman Peters, but the group of 10 moderates in the House, as well as House leadership, as well as Senate bipartisan leadership, working with the Republicans and the Democrats to try and find some solutions to many of these issues. And so this is an opportunity for us to get some feedback from all of you to look at areas that we might want to explore either now or in the future, and develop some of that dialogue with all of you.
Well, I'll just take us back to sort of that concept of exceptions or implementation of exceptions for, right? It seems like part of the challenge is how do you protect those products perhaps that are at risk, that are rare disease or have only rare disease indications, versus some of the other products that might have, although I certainly don't want to undermine, right? It's important for some of those larger products that, or more voluminous products that also seed that research and develop and protect their finding the utility in rare diseases. So I don't want to undermine that. Having said that, it seems like that's part of the sort of the policy debate. How do you protect these rare diseases in the rare disease indications in the context of the Medicare Part D redesign, right? That Jennifer, I think, was going back to some of what you were saying, right? It is almost like we have to find a path forward to how you can pick and choose what indications you're going to protect in the concept of that. And I think in a lot of ways, operationally, that has to do with, as you were saying, right? At the point of service, there's there's not a diagnosis code. So how can you determine who should be protected and not? But maybe that's some of where we should be focusing on. How do we find some solutions to implement some of those protections? And it seems like there's a startup on it in sort of in the 340B space, right? They had to solve some of those challenges as well for protections for orphan diseases in the case of 340B. So maybe there's something to build on there.
Yeah, I mean, I guess, one of the if you're going to go with it, an easy way, I would think if there's, if it has orphan indications, but also other indications, maybe you let it go, because then there's more ways to kind of to get that revenue for that manufacturer, kind of like, but if it only has orphan indications, or it has a small patient population, even without do you reconsider it? Maybe that is the exception. Maybe it's a patient something, maybe it's a maybe it is that 526 and that's it. Those would be if you're going to draw like a line, maybe that.
Yeah. Absolutely.
Yeah, I know this was a topic of conversation around the orphan drug tax credit proposal. There was, I believe, some language thrown out around exempting drugs that only have rare indications versus, but at the same time that would, there's potentially a lot of promise in studying drugs that get approved for a common disease first or non-rare disease first, and repurposing that and seeing if it can be beneficial in rare. And so we don't want to disincentivize that either. So that's, I think that's the challenge when we talk carve outs. What's the devil's in the details and what it really is addressing. So in the tax credit sense, while it would be beneficial for repurposing a rare to a rare, a therapy that was approved in rare to another rare, and still incentivize that additional investment, it might not do so. And we could lose out on, potentially beneficial products in rare. And with, again, 93 to 95% of rare diseases having no options, why would we want to lose out on anything?
Yeah, absolutely.
Makes a lot of sense, Jamie, and and particularly as some of these products are approved for very small rare populations, and they may then have an investigational plan to look at other very small rare populations with the same therapy. That could shift priorities and the inability of that product to even be viable with just the one indication.
Absolutely. And it could be a perverse incentive too, like unintended consequences, where with the way the carve out for negotiation is listed now, where we don't get, we get companies that aren't going to pursue more than one indication because they don't want to lose the carve out. So I think there's going to be trade-offs, and again, inaction isn't an option, but we need to do our best to advocate and tell the rare story, and really also in the meantime generate data and keep pushing forward those other innovative ways that we could find solutions in rare, because I think we all have to recognize that doing nothing isn't an option either.
Agreed. And as we look at just more broadly some of the Medicare redesign proposals that potentially could have shifted investment from orals to injectables, not intentionally. Of course that's not their intention, but the reality is that you could end up then with more investment in infusion and inpatient or outpatient injections versus an oral medication that can be taken at home, that can be taken conveniently, and utilized by a rare disease patient, often for a very complex rare disease. And so, those shifts could sometimes be very subtle as we kind of tinker with the incentives in various programs that don't necessarily look at the patient holistically.
Well, I think to that point, the National Economic Burden of Rare Disease study that we conducted and released earlier this year, I pulled some numbers, just to show that we aren't, our system's not set up to talk holistically about the problem, right? We're just not set up that way. But ultimately, of the 966 billion economic burden in 2019 alone, it was 437 billion direct medical costs. 437 billion productivity losses, indirect costs, 418 billion in medical and then uncovered in healthcare costs, other non-medical costs of 111 billion. But when you dive into that 418 billion in medical costs, it really only, let's see, 15% of the overall burden was prescription medication and administration, 15% of the overall burden was inpatient care. That was the biggest expense. And aside from absenteeism, and those are impossible, like you don't get that when you're talking about, drug pricing reform. You don't see the flip side of that, the 15%, in patient care that could be in part attributable to, so many people with rare diseases having no treatment options. And what happens to that number when they have innovation and treatment? And ultimately, 10% was outpatient care. 10% was prescription medication and outpatient administration costs, and outpatient care, another 6%. So, we're not targeting necessarily the biggest cost drivers. I think we saw that when with the focus on trying to attack, accelerated approval medications, ultimately when you dove into the data, they're not the biggest cost drivers of Medicaid budgets, but we're trying to really say it's a cost issue. And, there are many states now that are trying to propose, closed formularies so that Medicaid doesn't have to cover accelerated approval treatments. But I think that we're just not looking at the issue holistically because our policy systems aren't set up that way.
Certainly in the U.S., it's certainly hard to communicate that story to companies outside the U.S. They're like, "What are you talking about?" So certainly appreciate that dynamic. Well, I'm not sure, Katie, if you can open it up. I see Kelly Maynard has sent a comment. If you can't open it up to her, I'll go ahead and share it. She says, additionally, do you get the sense that members clearly understand the need to preserve orphan drug development in the overall efforts to decrease RX costs, or there are just a few unicorns on Capitol Hill?
Yeah, in a way, we might be victims of our own success. Since the Orphan Drug Act was enacted, there has been a surge in innovation and interest in rare disease. That's great, but the message we tried to send was, your efforts are working. Thank you. Don't mess it up. Your Congress provided leadership that really helped in rare diseases, but look at this big gap we still have to fill. And I don't think, to Kelly's question, I really don't think that there's a lot, there's many anyway. It's not widely appreciated exactly what that environment and the science looks like in these ultra rare diseases, especially.
Yeah, I think to add to that, Jamie, this kind of lends to the necessity for constant advocacy because of, staff turnovers, because of changes in members and priorities. The need for constant advocacy is so critical to helping them understand the importance of the orphan drug tax credit. Is that the people who actually put that credit in place and have kind of caretaken of it, guarded it, made sure that it was able to flourish, they're gone. They're not in Congress anymore. And so the need for constant advocacy, constant education, constant, helping them not only with those pieces, but here's the successes, here's the patients, here's, you know, why it matters. Those are so important. I think about, you know, some of my experiences on Capitol Hill when a member or staff comes in contact with a patient, particularly a patient who is there to talk about, say, the tax credit, or talk about the impact of payment changes, and say, this impacted my life. That sometimes is a meaningful, not only meeting, but it changes the member's perspective moving forward. And so I think that that kind of comes back and puts the burden on all of us, is how do we get up there in a way that they don't just kind of roll their eyes and say, oh, here they come again. But that we keep it meaningful, we keep it impactful, and that they can see that in a way that they can't do that, for lack of a better way to frame it. And I think that's part of the challenge with something that's successful on the Hill, is it's easy to fall back into the background if we're not up there doing that kind of work.
Yep, absolutely.
And that's why you have numbers. The numbers that we've been able to provide show that, you know, the costs just are astronomical for a small patient population. And there's just no way with that kind of change from a $24 million to a, you know, $370 million liability per year. There's no way that can't impact, you know, the organization and what they're able to do.
Well, thanks for all of that feedback. Angie, and I apologize for my cough. Angie, any thoughts or comments as we look to bring this discussion to a conclusion?
No, I think it's been a fabulous discussion, and certainly as we continue to press forward, that we've got lots of work to continue to do, regardless of what happens in the next few weeks. It's not gonna stop here, and I think from my perspective, I think it does go to some of that ongoing thinking about how do you continue to protect, how do you balance that with that research and development dynamic, how do you communicate that, right? I think to me that's the hardest, right? Because it goes down deep into the hidden priorities that are discussed behind closed doors about what happens with those research priorities. But we know that certainly there is risk to rare disease. So certainly appreciate the discussion.